Hi everyone, I hope I'm audible. You can use the chat box for the same. So we'll start in another 1 minute. So this is our first case. We will be discussing three cases today. And our first case was a 5-year-old female patient who presented to us with chief complaints of seizure for last 10 minutes, loss of consciousness for last 20 minutes. There was no history of hospitalization in the past, no family history of seizures. There was history of excessive crying, and then the parents thought around 2 hours back that it could be because of the bite. On examination in emergency, their heart rate was 140, BP was 78 by 32 with mean of 46, periphery is good, CRT more than 5 seconds, pupils normal, GCS even V1, M1, and there is no local sign of sting. Because the GCS was less than 8, we secured the airway, started ventilating the child. IV fluid bolus was kept in view of hypotension. Investigations were sent, which revealed that ABG has nearly within normal limit. Lactate was elevated. And considering the present scenario where systolic BP was affected more, we considered starting 100 dobutamine at 10 mics per kg per minute. Investigations further sent revealed slight leukocytosis with 89% neutrophil, and the urine for hemoglobin was positive. RBS was normal. In PICU, as we started dobutamine after one bolus, CRT was 3, BP improved to 98 by 62 by 52, and heart rate was around 122 minutes. Any guesses what we are dealing with on the chat box? Another 1 minute. Okay. We have shock, pain, very good, very interesting. So this is the right approach. Do not jump to diagnosis in emergency. Go systematically. Choose what is affected, solve it, prove it, go ahead. If your hypothesis is working, you're on the right track. If not, think more. Have a target that within 48 to 72 hours, either you find the diagnosis or you have right away way of handling things. Raised intracranial tension, maybe, maybe not. Uh, Pupils were actually within normal range, so we should consider it in differential. So we get a ECG done. It was normal sinus rhythm, 2D echo. On dobutamine, left ventricular ejection fraction was approximately 10 miles. So because there is a rapidity in presentation, in within 2 hours, child crash, no fever, no pre-morbidity, history of query bite. So in the season, there was excessive cry at the time, 2 hours back, and then after that, everything happened like this. Then we thought that this could be a scorpion bite. And once we considered scorpion sting, thank you for correcting me. Once we considered it is scorpion sting, we introduced prazosin, and gradually sensorium improved. We were able to extubate this child in 30 hours, and inotropic support was weaned off, and child was shifted after 60 hours and discharged to home after 96 hours. Now, let's go to another case. This is a 10-year-old child who presented with chief complaints of pain in right dorsum of sole and breathing difficulty. On history, this child was a healthy child. While returning back from under construction site, he felt intense pain in the right lower limb. While he examined his lower limb, he noticed these two pointers, which we are trying to highlight. And there were two pinpoint entry marks. And attendants got this gift for us, a dead snake. Post bite, child had complaints of slight pain in lower limb. There was increment in sweating. On examination, respiratory rate was 28. BP was 96. when 102 by 66, heart rate was 96, capillary fill time was 2 seconds, peripheries were warm, GCS was okay, E4, MV5, M6, local examination bite was noticed, but there was no arrhythmia. Systemic examination was within normal limit. One of you have mentioned that it is a neurogenic venom. So, do you still wish to go ahead with the same thing, or do you want to change? Eyelids and ptosis, nothing. Like I said, local examination only bites were seen. Examination, GCS, everything normal. System examination normal. BP normal. So emergency management in view of breathing difficulty, oxygen was started, ECG was done, IV cannulation done, anticipated everything, and ASV was arranged. Investigation revealed everything normal. ECG revealed sinus tachycardia. In PICU, observed for 24 hours, and there was no sign of envenomation. Anxiety decreased over 12 hours. Child was orally allowed after 12 hours. Shifted out discharge at 30 hours. Does this happen? Yes. This is snake bite. Someone says crate bite and delete it. This is snake bite. Not all snake bites are poisonous. Even poisonous snake also will not have every bite which is poisonous. But that doesn't mean that poisonous snake bite will always be non-poisonous. We can be wishful thinking, but there is always a downside to every poison. Now, this is the third case. We have a 7-year-old male referred from nearby hospital as declared dead. Status post CPR, intubated. As declared dead, a child was intubated with dilated pupil. History revealed there is sudden collapse, noticed by mother, who is a daily wage worker in the building, and there was history of snakes bite in nearby by the patient. On examination, child was on ventilator, respiratory rate was 24, heart rate was 96, BP was around 82 by 42 with mean of 60, capillary fill time 3 seconds, peripheries warm, GCS E1, VT, and M1. Local examination was not significant in this child. As BP was low, bolus of 20 ml per kg was given. External jugular vein was secured. Inotropic support with adrenaline at 1.1 mics per kg per minute was initiated. In view of a snake bite and in view of history of presentation with ptosis, fixed pupil, poor respiratory effort, ASV was started. Neostigmine was also initiated in ER. Neostigmine was continued in PICU every half an hour to 1 hour. Gradually, in 4 hours, pupil reflexes were back. Inotropic requirement decreased at 4 hours. Ventilatory requirement decreased at 6 hours. Child self-extubated at 8 hours. Continued monitoring till 16 hours. Shifted to ward at night. Discharged next morning. And a dead reckoning and child raising from the dead was the news. So these all happens. These are presentation of snake bite. A snake bite primarily doesn't mean that every bite is poisonous, and at the same time, it doesn't mean that it will not kill you in few minutes. We have to understand what is happening. So now we will be going ahead with a scorpion sting. There are around 86 species of scorpion in India, and only two are of medical importance: Indian red scorpion and black scorpion. And there is a widespread of endemicity of venomous snake bite on scorpion bite in India. Andhra, Telangana, everywhere scorpion bite are known. Although we should remember that they are not very aggressive. They don't hunt for the prey. They actually wait for it. They usually hide during nights. They hide in burrows, crevices, and they try to avoid light. Most of the time, human stings are accidental, and they usually happen when scorpions are touched while they were hiding. And with most of the stings occurring in hands and feet, so accidental injury with the scorpion sting happens when you are putting in your shoe in the region when it is left outside your door and your area is known to have scorpions, or you are playing around and then you went to get something and that was actually a crevice and you were trying to find something and scorpion sting happened. So scorpion venom is species specific. It has a short neurotoxin proteins. Some amino acids are free. It enters circulation rapidly. Tissue distribution happens with half-life of 5 to 6 minutes. Peak tissue concentration happens in 37 minutes, and it induces complication in all the organs. Most importantly, it acts on ion channels and alpha receptors. As ion channels are affected, it keeps the sodium channel open at presynaptic nerve terminal and inhibit calcium-dependent potassium channel reintake, thus lead to autonomic storm. When autonomic storm, then we see all kind of transient parasympathetic symptoms such as vomiting, profuse sweating, raw salivation, bradycardia, priapism in male, even hypotension. Priapism is the giveaway. If you have a case and this priapism with low BP is seen with the history of short history, think about scorpion bite. Prolonged sympathetic action will lead to cold extremities, hypertension, tachycardia, pulmonary edema, shock. And when we talk about scorpion envenomation, autonomic storm alone will not only lead to catecholamine release, there will also be decrease in insulin secretion, increase in lipolysis, increase in fatty acid degradation, and this ultimately will affect myocardial oxygen consumption. So catecholamine release, coronary vasoconstriction, decreasing with a more utilization of oxygen by myocardium, thus further catecholamine release. There is associated stimulation of renin-angiotensin system and increase in extracellular fluid volume. All associated myocardial dysfunction will lead to pulmonary edema, acidosis, myocardial ischemia, arrhythmias, heart failure. Over and above, because of vasoconstriction and associated autonomic storm, oxygen demand of the heart is increasing a lot. And failing heart will lead to cardiogenic shock-like feature at a very rapid rate with no fever. If neurotoxic local effects are seen in around 50% of cases, they are minimal or absent, and 50% have neurotoxic effects as well. There could be sharp burning sensation at the sting site, followed by hyperesthesia, pruritus, erythema, local tissue edema. Paresthesia is the last symptom to resolve before the patient recovers, and it is actually the most nagging one. So there are a whole list of important symptoms in scorpion bite itself, where if we want to pinpoint, sympathetic overdrive will lead to hypertension, arrhythmias, pulmonary edema, hyperglycemia, diaphoresis, convulsions, hyperexcitability. In our case, this girl had convulsions and hypotension. And the parasympathetic side, hypotension, bradycardia, bronchoconstriction, goose pimple skin, priapism, generalized weaknesses. All scorpion stings are not fatal. Some are benign, mostly are dangerous, some are fatal as well. And when we say about fatality, encephalopathic, convulsions, hemiplegic, cerebral hemorrhage, respiratory failure. So we were dealing in this child convulsions, respiratory failure, and query encephalopathy. Aggressive supportive measure helps in prevention of mortality and also decrease morbidity. In 0 to 48 hours, if the patient is moving from mild local pain, paresthesia, vomiting, salivation to tachycardia, hypertension, arrhythmia, myocardial dysfunction, and pulmonary edema, probably this patient is actually into potential dangerous zone. When we talk about central nervous system involvement with scorpion sting, encephalopathy and convulsions happen within 1 hour of sting, and stroke, both from cerebral hemorrhages and thrombosis, happen. Central respiratory failure also happens because of strychnine-like effect and spurt of BP secondary to catecholamine release. This lead to rupture of intracerebral artery, resulting in intracerebral bleed, which can lead to thrombosis due to coagulant nature of venom and autonomic storm induced vasospasm. This sign occurs within a few minutes, usually after the sting bite, and usually progress to maximum severity within 5 hours. The sign lasts for 24 to 72 hours and do not have apparent sequence. Furthermore, sometimes a total relapse is common and recovery is also false, so you need to monitor. Scorpion sting on cardiovascular will lead to primarily oxygen dependent cardiac dysfunction related problem, gallop rhythm, myocarditis, hypertension followed by hypotension, arrhythmias, conduction block, myocardial ischemia, infarction, leading to cardiogenic shock, cardiac congestive heart failure, before that pulmonary edema. All happens within 30 minutes to 3 hours after a sting due to myocardial dysfunction. Because of associated cardiac compromise state, respiratory dysfunction in form of dyspnea, cyanosis, hemoptysis, ARDS, along with gastrointestinal involvement leading to pancreatitis, pseudopancreatic cyst formation after pancreatitis, liver injury, necrosis of liver, in renal hematuria, oliguria, acute liver renal failure, and in metabolic because of autonomic storm, acidosis, hyperglycemia, hyperkalemia, raised free fatty acid, raised cholesterol and triglyceride. Pathophysiology is very important to understand because the injury, if not contained by reversing the autonomic storm, then continued the continued injury to various organ will continue with raised free fatty acid. The grading of severity in scorpion sting is done by a Sanath Krishnan grading. Grade 1 where peripheral circulatory failure and in grade 2 where peripheral circulatory failure with myocarditis is seen. Usually it is considered as good prognosis. And in the list where we were talking about benign potential dangerous, this come up to potential dangerous. In grade 3, there is associated CNS failure and it becomes a bad prognosis. Management part, it is entirely supportive. You manage airway, give breaths, then handle circulations. Oxygen inhalations are very useful. Injection TT, if the local site involved, then wash it, give TT. Manage seizure with benzodiazepine, give analgesia, apply local ice packs, xylopine infiltration, involve your pain medicine specialist, and give IV fluid, followed by the inotropic support of dobutamine. And most important drug which you should not miss in your emergency is prazosin. Prazosin, which is a competitive postsynaptic alpha-1 adrenoreceptor antagonist, is the first line of management if you're suspecting scorpion bite. It will suppress the sympathetic outflow. It will activate venom-inhibited potassium channels, decreases preload, afterload, blood pressure without increasing the heart rate, and it reverses the metabolic and hormonal effects of alpha receptor stimulation. Thus, answer to what is happening because of scorpion sting. Because of these actions, there is accumulation of cyclic GMP, which counteracts the vasoconstriction induced by endothelins and further prevent myocardial injury. This peak concentration of prazosin is reached in 1 to 3 hours, and plasma half-life is about 2 to 3 hours. Prazosin is basically antidote on cellular and pharmacological level, and it is also cardioprotective. It should be given. It is actually available in 1 milligram, 2.5 milligram, and 5 milligram tablets, and dose recommended is 30 mics per kg per dose. Sustained release tablets are not recommended in this condition. In fact, repeating dosage at the end of 3 hours, according to clinical response, is the way of handling such patient in pediatric intensive care. Later, after 6 hours, till extremities are warm, dry, and peripheral veins are visible easily, it should be continued. Always remember, benign presentation of scorpion sting also exists, and prazosin is a medicine which has it. It has its own side effects, so it should not be given as a prophylaxis in children where only pain is present and no other cardiovascular or other associated adrenergic symptoms are present. It can be given irrespective of blood pressure, provided there is no hypovolemia. It should not only be given in cases where there is the low BP. The time lapse between sting and administration of prazosin defines the outcome because it is the only medicine which works at the cellular level against the ill effects of scorpion sting. There are known scorpion antivenom. Unfortunately, in India, it is not available. And if it is present and if it is available, then it should be used within 30 minutes to reverse the effect of sting. What is usually considered as unhelpful, that is steroids, painkiller of morphine, pethidine, promethazine, chlorpromazine, nifedipine, atropine, captopril to handle BP and other associated problems. If not managed well, then there is coming up of cardiomyopathy. There is associated rhabdomyolysis, persistent paresthesia, ankylosis of small joint if sting occurs on the joint, respiratory arrest, cardiac arrest, shock, seizures, death. So the entire conundrum happens if we are not taking care of the most important aspect of identification, anticipation, delineation of symptoms of scorpion sting, and finally, utilization of prazosin. So, one thing as a pediatrician, what we should do, ensure that prazosin in 1, 2.5 or 5 mg should always be available in your emergency. One strip is not harmful, it is not very costly. and it is very useful if at all you deal with scorpion sting in monsoon or later monsoon and winter. In 5 stages, scorpion sting bite usually presents, and this one slide will be helpful enough for many to understand at what stage, what could be the treatment. We do not have anti-scorpion venom available in India, but prazosin and symptomatic treatment helps. If you see from 0 to 4 hours, increase salivation, sweating, mydriasis, priapism, hypertension, and cold extremities, and prazosin is the answer. It will help you in recovery. Stage 2, 4 to 6 hours, hypertension, tachycardia, cold extremities, again, ASP plus prazosin. Stage 3, hypertension, pulmonary edema, starting cold peripheries, dobutamine. Stage 5, Stage 4, massive pulmonary edema. Here you will have to manage hypertension. You have to manage associated complication of ARDS. So NIV, mechanical ventilation, prazosin, and if you have anti-snake venom, anti-scorpion venom, very useful. Although in India it is not, but in there are participants in this webinar as well from other nations. If you have it, use it. Stage 5, more than 12 hours, tachycardia, pulmonary edema, warm shock, hypotension, start dobutamine. Most important aspect of managing any poison is go symptomatic, start finding the cause. If you find the cause, treat it with antidote. Do not come down on symptomatic supportive treatment. Body takes care of the poison slowly, but it will at the same time get affected with the poison ill effects as well. What you should do to prevent scorpion bite in your community, in your society, and if you are residing in scorpion sting endemic area in India, then ensure that you inform nearby places, people that false ceilings under low style of roof and bamboo cord can store scorpion sting. Scorpion can move over there. In endemic area of venomous sting clothing, beddings and shoes, package should be vigorously shaken out and checked for scorpion without blindly putting hands. Sandal did not prevent sting. Pesticides like organophosphorus, pyrethrin, chlorinated hydrocarbons are known to kill scorpions. At the time of opening of schools, before usually maybe as the monsoon is about to start, so we in the schools it is required to thoroughly clean and wash all the table which also have a desk in. So there scorpion may be sitting and waiting. It is important to remember that scorpion venom is a potent sympathetic stimulator. Cardiac manifestations are common in Indian red scorpion. Both hemorrhagic and ischemic strokes are known to occur. CNS involvement indicate poor prognosis. Prazosin, which is an alpha adrenoceptor antagonist, is antidote to venom action. There is a question asked by Dr. Samir about prazosin even if hypotension start dobutamine. Dobutamine is required in warm shocks. Prazosin is primarily utilized to counteract the snake venom effect, which is leading to myocardial dysfunction. Dobutamine increases inotropic. With increased inotropy, the systolic BP will improve and it will not affect the oxygen consumption of myocardium. That is the relevance dobutamine is useful. So, time lapse between the sting and administration of prazosin, some most of the time determines the outcome. Next, we will be starting our discussion on snakes. So, in India, there are four common venomous snake varieties: cobra, crate, Russell viper, saw scale viper. Venom is practically synthesized by modified salivary gland and is stored and is given by the in the during the bite by the groove teeth called fangs, and it is entirely on the choice of snake whether to push or not to give poison. If the snake had eaten a meal, most of the time they don't want to bite. They want just to give that feel of threat and leave. It is estimated that India has highest snake bite mortality in the world, where around 83,000 bite with more than 11,000 deaths are reported by WHO. Most of the bite happens in lower extremity. Male to female ratio is around 2 is to 1. Do not forget this mnemonic. Do it right. When you have snake bite, make sure that you reassure the patient if you have an opportunity and you are at the site. Immobilize the limb as you will immobilize a fractured limb. Get to the hospital immediately and tell the doctors of any systemic symptoms you have measured. Do not try to put tourniquet. Do not try to push or pull venom with your bites. Do not get any traditional or herbal remedy over the wound. Do not waste time in um, doing any other thing but bringing the patient to hospital. Do not wash the bite site with soap. Do not put cut or incision on or near the bitten area. Do not use electric shock. Do not freeze or apply extreme cold to the area. Do not apply any kind of harmful soap or herbal remedy. All this we see, and even if we don't tell our patients or society and people residing near us whom we treat, this myths in our society can never be treated or can never be shunned away. So ensure you guide people at the same time you treat them when they are in need. Clinical feature when venom has not been injected are usually because of fear. There can be vasovagal syncope, even collapse, bradycardia. Another source of misleading symptom may be there, and mainly first aid and traditional treatments work, and then those people are regarded as doing the great job, but actually snake has not put venom into the person. What are the local symptoms and what are the signs if the part has been bitten? There can be fan marks. There can be local pain, local bleeding, bruising, lymphangitis, inflammation, blistering, necrosis, local infection, or abscess formation. Everything like a normal puncture wound of a skin that can happen when there is no venom being pushed by the snake, but only bite is there. But if there is associated problem, then patient will see generalized symptom such as nausea, vomiting, abdomen pain, drowsiness, palpitation, weakness. In heart, with mostly a viperidae family, there can be dizziness, fatigueness, collapse, sudden shock, hypotension, cardiac arrhythmias, pulmonary edema, even cardiac arrest. There can be continuity of bleeding from recent wounds, specifically fang marks will bleed. There can be bleed from gums. The vein puncture which we do will bleed. Sometimes there are old wounds on the body, they will start spontaneously bleeding. There can be bleeding from gums, bleeding in tears. There can be bleeding in from upper rectal, in vomiting, vaginal. There can be presence of petechiae, ecchymosis, and if it is neurological injury after neurological affiliation after snake bite, then probably it's Elapidae or Russell's viper. So drowsiness, paresthesia, abnormality of taste and smell, heavy eyelid ptosis, external ophthalmoplegia, paralysis of facial muscles, difficulty in opening mouth and showing tongue. There can be associated respiratory and generalized flaccid paralysis. Skeletal muscle breakdown will lead to generalized pain, stiffness, myoglobinuria, kidney failure, hyperkalemia, even cardiac arrest. In Viperidae family, in sea snakes, there is associated lower back pain, hematuria, hemoglobinuria, myoglobinuria. There can be symptoms of uremia such as acidotic breathing, hiccups, nausea, pleuritic chest pain. This These are the two typical signs when hemorrhagic manifestation after snake bite is seen. That is spontaneous bleeding from gingival sulci, and second is broken neck sign in envenomation by the crate. There is one test called 20-minute whole blood clotting test. Should be considered as a reliable test of coagulation. It can be carried out by bedside, and this is usually carried out every 30 minutes from admission to 3 hours, and then hourly after that. If you are managing a snake bite child and you are anticipating complications because of envenomation, ensure that when you prick prick him or her nicely with one prick, try to get the samples, and in samples send hemoglobin platelet, make a peripheral smear to get a PTA, PTT, D-dimer, FDPs, urea, creatinine, potassium, try to get um, urine also for the hemoglobin urea, myoglobin urea, check for RBC, proteinuria. ABG is advisable if cardiogenic involvement is there. Treatment happen in phases. There can be associated pain, which should be managed with adequate pain step ladder pattern. And most of the time we receive patient with tonic in place, so we have to handle tonic wisely. Most important mainstay of treatment of snake bite is anti-snake venom. So there are administration criteria, dosage, and treatments which are needed, adverse reaction which we should watch for, whether we should repeat the dose of ASV, what should we do when there are late arrivals. So let us see what we have to do. So pain should be managed with either oral paracetamol or you go with tramadol. NSAID should always be avoided in such cases where there is risk of bleeding because NSAID leads to. Can anyone tell what is the effect of NSAID and why it should be avoided in case of bleeding? I'll wait for the answers in the chat box. When we are dealing with someone with handling tonic ideally tonic are not recommended. But care must be taken while removing them, as sudden removal can lead to surge of venom leading to paralysis and hypotension. Before the removal of tonic check for presence of pulse distal to it. If it is absent or occluded, the distal pulse is occluded, then blood pressure cuff should be applied and pressure should be slowly reduced. Anti-snake venom is the mainstay of treatment. In India, there is polyvalent ASV, which is effective against all the four common species, and no monovalent ASVs are available. So there is no role of getting the snake variety. We are not going to choose our treatment as per the say snake which we are looking at, but we will give polyvalent ASV. So rather than chasing snake and getting another bite victim, it is better to leave the snake and treat the patient. ASV is produced and is present in lyophilized form and in liquid form also, although there is no evidence to suggest which one is better. Liquid ASV requires reliable cold chain and has 2-year shelf life, and lyophilized ASV in powder form has 5-year shelf life and requires only to be kept cool. Now, when we talk about anti-snake venom, it should only be administered when we have uh, signs of envenomation. And these signs of envenomation should be either coagulopathy or should be neurotoxicity. And there can be severe local symptoms also. These local symptoms will range from swelling of the joint, rapidly crossing, involving half the bitten limb in absence of tourniquet. Once the tourniquet has been removed for more than 1 hour, if the swelling rapidly continues, then it should be viewed as venom generated and not due to continued effect of tourniquet. There is prophylaxis which should be kept ready, which comprises of hydrocot 10 mg per kg and antihistaminic 0.2 mg per kg IV. If after starting ASV we see any kind of rash reaction or problem, we treat it. We wait for 15 minutes and we retreat and we restart. And you should remember that ASV test dose is not recommended in any of the patient. ASV initial dose, mild envenomation where systemic symptoms are manifested after 3 hours after bite. Either it is neurotoxic or hemotoxic, is 8 to 10 vials. If it is severe envenomation, less than 3 hour bite, neurotoxic or hemotoxic, it is still 8 to 10 vials. Each vial is 10 ml of reconstituted ASV. Children should receive the same dose as adult because snake is not going to give you less poison if you are a child or an adult. They will bite, either they will put a poisonous bite or without poison bite. If poison is injected, it needs to be neutralized with required amount of dosage, where each vial is 10 ml. Around 10 vials, 8 to 10 vials are utilized. It should be administered after the constitution over 1 hour. There is no benefit in giving ASV over longer duration. Rather, it only lengthens the treatment and time for your further evaluation after ASV, whether it is being able to neutralize the venom or it is counterintuitive. Yes, ASV being a biological product, it has its own adverse reaction. It can be anything ranging from urticaria, itching, fever, chills, nausea, vomiting to hypotension, bronchospasm, and angioedema. If you see such adverse reaction, discontinue for some time. Give 0.5 mg or 1 is to 1000 adrenaline IM. In pediatric dosage is 0.01 mg per kg body weight of adrenaline IM 1 is to 1000 dilution. Check after 10 to 15 minutes about patient condition. If not improving, give second dose of 0.1 mg per kg of 1 is to 1000 dilution. If this can be repeated for third and final occasion, most of the time within 2 doses, adrenaline is sufficient. Once the patient has recovered, then restart ASV. Don't wait further. Evidence has shown that adrenaline reaches necessary blood levels in around 8 minutes through IM route and around 34 minutes is taken if it is subcutaneous route. When should we consider repeat dosage? In anti-hemostatic bite, once the initial dose had been administered over 1 hour, generally no further ASV is given for 6 hours. In 20-minute whole blood clotting test, PTA-PDT should be done after 6 hours. It will determine if additional ASV is required after that, because this is the usual time which liver will take to restore the clotting factors. If whole blood clotting time is more than 20 minutes, then again repeat dose of around 5 to 10 vials, half to one full dose should be given 6 hourly till coagulation is restored, or we have polyvalent ASV which is ineffective, so we wait. There we have four variety of snake venom which is being taken by polyvalent ASV, but there are many unknown variety of snakes with unknown poison. So we should be open to this thought that probably this snake is not covered with our polyvalent ASV. There is an important consideration in neurotoxic snake bite, that is neostigmine test. This is important because this only saved our child. So patient with clear objective evidence of neurotoxicity, that is ptosis, inability to maintain upward gauge, respiratory weakness, should receive a test dose of atrophonium or neostigmine. We start with neostigmine. We pre-treat with atropine. Now there is no minimum dose criteria. You can go with 0.02 mg per kg. You have to start with 0.02 mg per kg IV of neostigmine. If there is subtle evidence of improvement in 30 minutes in form of no more deterioration, then you repeat this dose every half an hour to 1 hour. And you also need to make sure that atropine in given along with it over 8 hour duration, 0.02 mg per kg. Closely monitor airway, and because this child was received in with intubation, so airway part was secure and we were able to handle the mortality part easily because the airway was secure. There was no associated comorbidity in the third case which we discussed. And this neostigmine we continued for the child nearly every half an hour, 45 minutes to 1 hour, and we were able to safeguard with atropine as well. Why atropine? Because neostigmine works by inhibiting acetylcholine esterase, which is an enzyme which breaks down acetylcholine, which is crucial for muscle contraction. By increasing its availability, neostigmine will overcome venom-induced blockade and improve muscle function. It also will have muscarinic side effect, and to take care of those, atropine is important. And by blocking not only atropine will have not only effect of muscarinic, it will also block action of acetylcholine. But we have to ensure that we balance out the ill effect of neurotoxic snake bite along with rapid utilization of resources and right utilization of medicines. When we talk about repeat ASV doses in neurotoxic envenomation, then ASV regime is not very clear in neurotoxic envenomation. After 1 to 2 hours of initial dosage and neostigmine test, patient should be reassessed. If symptoms are worsened or have not improved, second dose ASV should be considered. Total 10 vials should be considered if initial dose has not worked, and then third dose should not be considered. Once the patient has received respiratory failure and you have totally given 20 vials to the patient, it is assumed that whatever snake, whatever bite, whatever venom is there, hemotoxic 30 vial hemotoxic, yes, that is okay. In neurotoxic 20 vial is the cutoff. Hemotoxic after 6 hours, you decide accordingly. And finally, in certain centers, you can go up to 30 vials also. But that decision is taken once you have cross-checked with uh, coagulation profile if you have the facility available or if the spontaneous bleedings have not settled. Victims who arrive late, you perform 20-minute whole blood clotting test to determine if any coagulopathy is present. If it is present, ASV should be given. Otherwise, treat the renal failure because of associated myoglobinuria, kidneys will be clogged. In case of neurotoxic envenomation, it is wise to administer 8 to 10 vials of ASV to ensure that no unbound venom is present. But usually, most of the venom in this stage is already bound and respiratory support will be required, just like the case which we have received. Response to initial dose of ASV if it is not if an adequate dose of appropriate antivenom has been administered, it is usually seen that patient will start feeling better, nausea or headache and generalized aches and pain will disappear quickly. There can be associated decrement in spontaneous systemic bleed in 15 to 30 minutes. Blood coagulation settles down after one dose of ASV within 3 to 9 hours with the 6 hours tops is considered as adequate time for the liver to generate. In shock patient, BP need to be increased and arrhythmia need to be managed. In neurotoxic patient, they generally start showing improvement within 30 minutes after antivenom along with neostigmine. For our cases, and for in this usual discussion also, discharge usually follows very soon. If the patient for some reason is discharged within 24 hours, they are advised to return with risk factors associated with bleeding spontaneously, any associated pain and swelling, any associated difficulty breathing or altered sensorium. And patients should be explained about serum sickness, which can manifest after 5 to 10 days of anti-snake venom. We should not forget that serum sickness is type 3 hypersensitivity, where body is going to react to outside protein, and this same thing can happen with various biological products, and it is characterized by formation of immune complexes that will get deposited in various tissues, lead to inflammation and range of symptoms. Treatment is usually managing it with antihistaminic, and if the symptoms are severe with renal injury, associated hospitalization is also needed. With this, we conclude snake bite and scorpion sting. I have asked a question of why there is bleeding after NSAID. So, yes, the risk of bleeding is increased. They have antiplatelet action. Yes. Why? Because basically the NSAID, they usually impair the adhesion part, platelet function, and new platelet technically will not function. They will not primarily affect the existing platelet, but new platelet will be less functional. In uremia, in renal failure associated with the snake bite, the elevated urea will actually coat existing platelets and they become they will not stick and they will not make the clot. So existing platelet are affected because of uremia and new platelet are affected because of NSH. So overall, it will be double whammy, and that's the reason there are more chances of more bleeding and mortality is high in cases whenever we are dealing with bleeds and we start using NSH. There are two suggestions. First is by Dr. Umesh Vishwakarma about neurotoxic 20, hemotoxic 30. Well taken. What is the maximum dose of ASV? Dr. Koteshwar, Dr. Umesh has already mentioned. So the rationality behind ASV is that if snake has bitten and there are hemotoxic symptoms, coagulopathic symptoms, then neostigmine does not work in crate. So because you do not need to identify the species of snake and it is important to go step by step. You identify snake bite, you check whether there is associated swelling, bleeding, coagulopathy associated symptoms. Don't give neostigmine at this phase. If there is associated paralysis, there is associated complication of muscle injury, renal failure, neostigmine probably will be useful. And um when we have polyvalent ASV, we can only manage four type of bites. And great bites are very tricky. Make sure you remember two baseline rules of managing poisoning of any cause. Symptomatic is support is the mainstay, and if you are able to identify the plan, then you stick to that. Neostigmine is recommended in neurotoxic snakes. Crate is known offender, and sometime neostigmine will not work in crate bites, and sometime whatever we see. um in crate bite, the crate and crate venom and venom of cobra, they are entirely different. So we'll not go into detail of which type of venom and why. My simple suggestion for practitioner is go step by step. If neostigmine is working, you utilize it. Let the ill effect of neurotoxicity reversed with neostigmine, and venom is neutralized with anti-snake venom. If it is coagulopathic, hemotoxic, then you give ASV, there is no role of neostigmine. Crate, viper, cobra, you try to identify the snake. And if the snake which they have brought is not the snake which has bitten, and you miss on giving the right treatment, then you will see loss of life. I strongly suggest avoid that this type of decision making where you want to see which variety of snake it is to go ahead and plan your further steps. Then Dr. Ravinder has asked whether hydrocot and Avil are mandatory. No, they are anticipated drugs which should be kept on bedside, like you should be keeping midazolam in a patient whom you are dealing with seizures. Similarly, when you have to manage with biologics, which are known to cause reaction, then you should be keeping hydrocot and Avil on bedside. Um, so Dr. Sumati asked whether 10 mg per kg hydrocot is a big dose. Yes, it is, and cap is 100 mg. If you see for a child who is 15 kg, this seems to be very high, but a child who is 60 kg, this seems to be less than 2 mg per kg. So cap is 100 mg. It should not go beyond that. And inflammation and associated effect of reaction is what it makes useful in these circumstances. With this, I know very in urban India, snake bite, scorpion stings are not very common, but most of us we have seen, we forget and to manage these poisons, but we should not forget because when we are prepared to handle such cases, then we are working in the right way. And uh, scorpion sting and snake bite, they are killers if not managed well. So get ready. Please keep ASV 10 vials and prazosin in your ED along with neostigmine handy. In fact, in upcoming presentations, I will be covering various common toxins. So we should be making kits in our EDs so that we can